Hi. I'd like to share some of one case study I mentioned earlier on about the workflow side of the implement in the hospital. What are the things you need to consider? And already mentioned a little bit, if you look at FDA, we do approve quite a bit of AI product already. It's already in the clinical care. A lot of them are mostly in radiology and cardiology. A piecemeal. You say, this is what we have. Mostly you can imagine is machine learning, pattern recognition type of things. That's very common. The issue is also, besides this, we actually a lot more robotics, omics, sensor, all these things you think is really far away, actually it's come closer to the home. Even your socioeconomic data, we have been utilizing in taking care of the patients. And current implementation AI is focused on specific tasks. You look at those approved by FDA, you can tell, it's just one thing. And how to integrate all these tools, toys or whatever you call it, systematically integrate into the total workflow such that helping the patient, the whole clinical care is really an ongoing issue right now. And I'd like to give you one case example we have done. We do a couple of them. This one is one thing about stroke. And everybody knows stroke is a major issue about number 2 death. In America, we have about 800,000 people die every year. And stroke actually is a diagnostic problem, frankly. Time is brain. So that's the reason why AI is important in diagnosis. It's treatable if we know you have stroke. The problem, a lot of time we don't, we miss you. And then by the time you're getting irreversible, we can't do anything. This is a workflow about the upstairs. Up one is the existing ER workflow. You come to the ER room. So patient come in, you triage it, look at it, whether you have asked you to read a story and see how it movement, all these things, whether you have stroke syndromes. And if possible, and then we do some CT scan on your brain. And mostly started with non-contrast CT. And then later on, maybe CTA, CT perfusion. And then put all the other impression, and if you decide you're stroke, and then you go to evaluation, and then do treatment right away. And this is existing workflow. So we look at all these points. We look at all the pain points, say what are the inefficiency in the whole total process? How can you improve it? And I want to say example like triage. Triage we did actually challenge in acute. Let me already talk about the CT. CT is most ER room exclusively, probably 99.9% is on CT. It's very noisy, and in the first less than 3 hours, we can't see anything, the infect. And we don't have many specialists, especially in the small hospital in rural area. And what happened? He died. Okay, come up. And MRI is a standard. Unfortunately, MRI is only in hospital, only for monitoring. And right now, this is statistic. You like it, don't like it. This is national statistic. We overcall 30% of cases, and we miss 20%. We miss those mild, you have a big stroke, you can tell. Moderate, mild, microsegmentation, you miss it a lot of time. Basically, flip a coin. Half the call are wrong. So what we did, the triage stage, we're using audio, right? I mean, just basically a cell phone. Same thing, we take a picture, take a video, and ask them to read the story. So we look at your facial, 3D facial, and audio, analyze both data, apply deep learning, and try to triage you. And this is done actually. We have, is it working? What happened? And then we go back. We already implemented an app basically. And this app just replaced the triage nudge, where you look at it, 3D facial, and also read a story on this part. And this is the statistic, the feasibility study we've done by gender, age, ethnicity, and race. And this published last year. Now we're about 300 cases. This one just 60 cases. Our algorithms will perform everyone, including physician. This gives you more data, more detailed data. CI, clinical impression, means emergency doc. We cannot compare with nurse with emergency doc. Emergency doc, a human being who have everything in the emergency room. And you look at the accuracy, just the video app, the AI app, and can get about 72% accuracy, higher than the 69% of the human. And this is not surprising, frankly. If you know what you are doing, AI actually suppress performance better than human. If you know what you're doing, focus on one problem. And the only thing is I mentioned a little bit about in the race part, I noticed that the red one I point out, the African American is a lower, 0.55 in terms of AUC. I go back to look at the data, and we find out actually we don't have that many African American patients in the beginning. So the system little bias out there. Since then, we compensate. So my point is AI itself is biased. Make sure your algorithm is very good. Right now, we compensate quite well. And so this is the part we are right now doing a prospective trial, about 1,000 patients in our 8 hospital center. And it will be interesting to see. The second one, I want to show you the CT part. After this, I remember the whole idea is not piecemeal. It's integrate them together. What are the AI automation you can do? And I mentioned before, right? CT is, we missed non-contrast CT, the workhorse in the ER room. We missed about ischemic stroke, 2/3 of them. And the reason, but we cannot increase the dosage because you're adding radiation damage. So at the same time, it's a dilemma. So we try to think about, can AI do something about it? And we do, actually. We look at the data, and what we do is, I go back a little bit. We're using longitudinal CT scan of the same patient, 6 or 7 of them, put it back into integrated system, and generate a particular algorithm. And this is called we call it SRAD, GCNN. This approach, the one in the, I can't see, but the one on the far, if you look at the original CT, you can see very noisy. This is actually the physician looking at. That's the reason it's so noisy. And state-of-the-art AI is the middle. The one we have, the quality we measure is much better. This is about 300 patients. It's published work. And this is really model dependent. I don't care which scanner, the performance is still consistent. So we have the noise, keep the signal the same, reduce the noise, with 10 times more than a normal dosage, virtually, by taking advantage of the previous scan of the same patient, 300 patients. So this is the only one denoising algorithm available, right, for that. And this example will give you some idea. It's very hard to say. The one on the original on CrossCT, I have a greens, you probably can't see very clearly, it's a green part in the middle. You can see that's what the machines see, one peak, but we know there are 2 tissues. After denoising, if I circle same part, the machine can distinguish that. There are 2 different types of tissue. That's the reason how you can tell the differences. And these are the cases, where the old cases that radiologists, ER doc missed, and we're using our denoising algorithm. They read it again. They forgot what case it is. It's probably half a year later already. But they can pick it up faster than AI. Faster than basically, the previous misdiagnosis case, they pick it up quickly. Instead of at the end, on the DWI, the diffusion weighted image, that's the one that when the patient is already hospitalized, that's what we do, it's too late. And some of these patients actually, unfortunately, die actually. If we can catch up earlier, we can avoid this tragedy. And we also measure under different region, the gray matter, white matter, thalamus, different areas, and compare our result quantitatively, and result is consistently better. And one lesson we learned from it is interesting. You notice that I'm not using a lot of data. I only use about 300 patients. So if you know your physiology, you know your biology, you don't really need so much data to train your deep learning model. And this is something to take up. Domain knowledge is absolutely important. And the other thing is, I know AI deep learning, a lot of us like to do synthetic, do data augmentations, increasing the data set. Is bad in this case. I try to reduce noise. Data augmentation, adding more noise. Don't use it. But these are some lessons we learn. And right now, we put this thing into a box, a DICOM box. DICOM is a standard for the image communication. Can I turn it on again? What happened? Okay. It's a GPU edge computing put inside a box. So it's just a small box like this size. I can plug it into the hospital network. I can talk to the scanner. I can talk to PACS, talk to the workstation. I don't need to talk to GE, Philips, Siemens, right? Just very easy. So right now we can just ship it here, send it back with DICOM back to the scanner. The radiology can read it right away, the quality. And that's a way. Everybody go for cloud computing, we'll go reverse direction. It's going backward. We're going to edge computing. We want to take control from the cloud. Once you go to the cloud, actually lost a lot of control. And the last thing I want to show another example is about evaluation. We put all these things together, all the index. We are testing this index, whether it works or not working. We quantitate it. But this is an interesting one we are ongoing right now. It's also in treatment. I show you triage, diagnostic. This is the treatment part. I say there's no shortage of treatment. If I know that is a stroke, right away we can do it. And one approach is phlebotomy. It's very common, cerebral interventions. And depending on what you stroke, you call phlebotomy, if you aneurysm, you call embolization, carotid atherosclerosis, angioplasty. It's the same idea, basically. Put a wire in, and then go into the right area and then clear up the area. This is very highly skilled, you can tell. Very time independent. There's not that many people had this type of skill. The problem is, can I move? Right? So blood clot need to be removed within 6 to 24 hours on the symptom onset. Otherwise, it's just permanent damage. Can't do. So timing is very important. And these are the EVO, the emergency large-scale occlusion is about 30% all schematic case. Interesting statistic though. We've done about 200,000 US, 1.7 worldwide. But reality is only about 15% to 20%, 10% actually. We actually done 10% of eligible patients. They should go through this procedure to cure the stroke. We did not. We missed 90% of them, basically, because exactly the point I want to is there are many reasons. One of them is we miss during the triage, we miss in diagnosis in your room, or we don't have enough specialists to be around to help them. And try to, in the case we try to do that, try to approve it. So we think about whether AI or even telerobotics can really make the equity of the access easier to the physician. So give you some idea, a very simple idea of phlebotomy. Basically, very simple, right? You're using C-arm or CAF. You look at it, look at the image, and physician did a wire. And basically, the process is very simple. You see it, see the catheter, you see the artery, and you know which artery is the catheter in, so you go to the right area and clear the clot. It's a very simple procedure, but highly skilled. It's a very delicate procedure, and you control it. And this will give you some idea, the challenge, right? Normally, you have many wires in the body, and the machine will be very confused. Very noisy, and very poor contrast, and the pixel are less than 1% of overall pixel. You need to be very, very accurate, and many wire-like structure in the same area, as you show in this picture. So it's very confusing for AI. So how to do it? We actually developed, without detail, this is already published. We actually using an AI algorithm. We look at input data in real time. We can look at catheter segmentation, and then we go through the vessel segmentation at the same time. Catheter segmentation tell you the wire where to go. The vessel show you where the wire, the vessel around. This is really for human, frankly. Machine doesn't need it. And then we integrate together and go to the rich area. The whole process is automatic. And this is the so-called deep learning, deep position tracking on these new native fluoroscopic sequences. And our result is very good because the overlapping 0.95. I mentioned about we need to reach 10%, is much better than 10%. So the accuracy is very good. And I'll give you some example. The middle one is a ground truth. The right one is the AI predicted. The wire go in and go to the right spot. And the bottom are these are patients. in terms of their dice ratio score. Dice score means that how much overlapping with the real and the prediction. And the result is stunningly well. We're very exciting about this result. And the next step, we will integrate into robotics. The whole idea is really about cleaning the clock itself is easy. Remember the wire normally come from the neck, the timer go up to the body. It's a long process. Some of them using arm. It's very highly trained. And most of patients cannot get this procedure and get suffer for life because there's not enough specialists around in time to do this procedure. And that's when we want to automate this process. For even ordinary surgeon can do it. Once you get there, ordinary surgeon can do that. You don't need a specialist anymore. So to summarize a little bit, just give you a case example. What's the motivation? We look at the whole total workflow. I took a stroke at the case. You can imagine some other cancer or other cases, it's the same idea. So AI automation, I'm really excited about transformation in healthcare, but it requires integrations of different data and also complexity of different sensor data, robotic information. Focus right now is a piecemeal automation, as I mentioned, it's not optimized. We are going to the next stage to be making an impact, really deciding well in the workflow, how to integrate together. So to adding the overall patient care and experiences, and this require, I think in the panel we mentioned, you need design, you need oversight, evaluation, ongoing monitoring. This is a new thing that IT may not be capable to do it at the moment. You need to be retrained IT workforces, just like a system. And one thing I don't like is this one is fine, but the other thing is, if you really want to replace the physician, I don't want to get a physician outside the loop. I always want to do that. For a mundane task, they should not do it because it's repetitive. You should spend more time with the patient on the bedside. So like telemedicine, right? Telemedicine is a dumb telemedicine. It basically is two people. You're still tying two people. Imagine early on, if I have this, we are doing telestroke. Imagine I have this video, the video app for looking at it. The guy can log in remotely. They just look at themselves, we evaluate right away, get a result. Just a telestroke. So the next step is improvement, and also there's a lot of lifelike avatar. A lot of people talk about ChatGPT, adding empathy. Right now, AI is very cold. Very accurate, fine, but missing the human component. How to put it in is still an art. We are trying to learn how to put it in. Remember, patient has to trust you before they let you do on it. I mean, it's very important, trust relationship. And all these require some redesign sometimes. Whenever you put a new exciting technology, useful technology, into the workflow existing process. You have to optimize it. In no way you say using old process. I know the IT will say stick as it is if it's very inefficient. Because your process make the old process kind of obsolete. You make it more efficient, more effective. So you need to redesign it to get a better value out of it. I can't do it myself. It's a party for my lab and for some of my colleagues I have a wonderful team of colleagues, physicians, scientists, and graduate students, and my neighbor, MD Anderson and Penn State, my students. That's all quickly, sorry. That's all I have, very quick case.